Good morning, Doc. Sorry for the delay, Doc. So we will just start, Doc, without them, Doc. Do not to waste some time. Hello?
Okay, let's start.
Klaro ako, Jules. Let's start. Next slide, please. So for the case, RG, 40 years old, Gravida 1, Para 1, 1001, came in for dizziness with heavy menstrual bleeding, noted for 6 months, characterized as perfused using 4 adult diapers per day, 10 days duration, 30-day cycle with associated dysmenorrhea with pain score of 8 over 10 relieved by mefenamic acid. She went to a private physician a week prior and advised intake of tranexamic acid 500 milligrams capsule every 6 hours if with profuse vaginal bleeding. She was also advised ultrasound and CBC but did not comply. Now, the patient is in her second day of menses, so past menstrual period is April 8 to 17, 2022. Menarche was at 13 years old, regular cycle, 4 days duration, 3 to 5 pads per day, and moderately soaked, with occasional dysmenorrhea. So first sexual encounter is at 24 years old with one sexual partner. No history of contraception, nor pap smear nor STIs. Past medical history is unremarkable and no medications taken. Family history of cancer, hypertension, and diabetes mellitus. For the physical examination, BP of 90 over 60, heart rate of 102 beats per minute, respiratory rate of 24 cycles per minute, temperature of 36.7 degrees Celsius, auto saturation of 98%, height 5 with a weight of 72 kilograms, pale palpebral conjunctiva, anicteric sclera, no LAD, no neck mass, soft abdomen, and noted a slightly tender, baggy movable mass with SP2 above the pubic symphysis. Speculum examination, cervix midline, smooth, no masses. For the BPE, introitus is varus, cervix closed, non-tender, uterus at 14 weeks size, globular, baggy, slightly tender, adnexa is negative and with minimal vaginal bleeding. So for number one, what are the salient features in this case? For the general data, our patient is a 40 years old with obstetric score of Gravida 1, Para 1, 1001. Then with dizziness and with heavy menstrual bleeding for 6 months and with associated dysmenorrhea, perfuse, perfuse 4 adult diapers with a duration of 10 days, 30-day cycle, dysmenorrhea with a pain of 8 over 10, relieved by mefenamic acid. Um, Family history of cancer, hypertension, and DM. For the physical examination, um, heart rate is 100, 102. Ah, Doc, our group member is already here, Doc. So you can continue, Ru.
So for our heart rate is 102 beats per minute, and for respiratory rate is 24 cycles per minute. Temperature is 36 degrees Celsius. For auto saturation is 98%, and the height is 5 feet, and weight is 72 kilograms. So the patient has pale palpable conjunctiva, anesthetic sclera. The patient has soft abdomen and noted a slight tender, buggy, movable mass with SP2 above the pubic symphysis. Next, please. For the BPE, the patient is introitus parus, cervix is closed, non-tender, Uterus is 4 to 6 in size, globular, boggy, slight tender, agnesia negative, and minimal vaginal bleeding. Has a minimal vaginal bleeding. Please.
So for LO number two, what else in the history that were not mentioned but would help influencing the diagnosis? So next slide, please. We have the following questions for our patients, such as in menstrual history, we can ask our patient any history of intermenstrual bleeding. In for surgical history, we can ask our patient any history of dilatation and carotid use. And then for sexual history, we have the following any history of dyspareunia, history of postcoital bleeding, and in contraceptive history, we can ask what type of contraceptive were used. For family history, we can ask what type of cancer runs in a family. For review of systems, we can ask for the following: history of thyroid disorders, history of anorexia or unintentional weight loss, history of depression, history of bleeding from gums and nose.
So for the LO number three, what are your sorry,
For LO number three, what are your three differential diagnoses basis for ruling in and ruling out? Next slide, please. So, first, let's discuss the causes of abnormal uterine bleeding, and this can be the causes can be described by the FIGO, or the International Federation of Gynecology and Obstetric Classification System. It subdivides the causes of AUB into 9 main categories. The first subgroup is constitutes the structural or the histologic causes that are diagnosed through imaging or biopsy. And this includes uh, the mnemonic palm. So we have polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. While the second group are non-structural and includes the mnemonic PON, or coagula, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and the not yet classified group. So next slide, please. I will narrow down the causes into three. So our differentials for this case are the following: adenomyosis, endometrial hyperplasia, and leiomyoma. We ruled them in because the most common symptom of these three diseases is abnormal uterine bleeding, which presented in our patient as heavy and prolonged menstrual bleeding. Additionally, physical exam showed palpable and enlarged uterus, which is usually the result of, first, the inappropriate endometrial tissue proliferation in adenomyosis, the excessive estrogen exposure with relative progesterone insufficiency in endometrial hyperplasia, and the increased expression of estrogen and progesterone in growing fibroids or leiomyoma. Moreover, based on the physical exam of the patient, now the patient is class 1 obese, and obesity is also a major risk factor in all three diseases. So, um, for the first, the endometrial hyperplasia, we ruled this in because majority of patients present with a change in the menstrual bleeding pattern and alarms them to seek medical help. In the history of our patient, her heavy and prolonged menstrual bleeding started 6 months ago. Moreover, in the family history of our patient, cancer was also mentioned, although we haven't asked what type of cancer it was. And then, um, um, however, for its incidence, 15% of cases are diagnosed. Only 15% of cases are diagnosed in premenopausal women, but it does not really exclude our patient since she is at 40 years old. Next, for leiomyoma, aside from its incidence, among premenopausal women, leiomyoma was also ruled in because of the physical exam findings of the movable mass and enlarged palpable uterus common in its diagnosis. However, leiomyomas have irregular enlargement of the uterus. Lastly, in adenomyosis, risk factors include, again, premenopausal women in which your patient's age is 40 years old and it is still in the range. Patients also may present with secondary dysmenorrhea, which your patient has. And last but not the least, a diffusely enlarged tender, boggy uterus is suggestive of adenomyosis. However, the confirmation of the diagnosis of these diseases require imaging and will further be discussed on the next LO. So next slide, please.
Move back one slide. Um, Not all uterus in endometrial hyperplasia is palpable and in adenomyosis because some patients presents with adenomyosis that has small uterus, and most patients also with endometrial hyperplasia, you do not palpate the uterus because they have small uterus. Patients with leiomyoma, especially with those submucous myoma, where it is found in the cavity inside the cavity, so you cannot palpate also the uterus. If you have the smaller myomas, you can palpate uterus in bigger leiomyomas. And then for the globular, boggy, slightly tender enlarged uterus, not all again enlarged in endometrial hyperplasia. Most patients present with small uterus. And then they only find it having endometrial hyperplasia through biopsy. But most of the patients have small uterus. For patients with adenomyosis, most of the patients have globular boggy uterus. When some patients also present with small uterus even though they have adenomyosis. So not all patients presents with enlarged uterus for adenomyosis. For leiomyoma, again, if you have the subserous myoma, the bigger myomas, then you can palpate the uterus. If you have the intramural with subserous component or the subserous myomas, then you can palpate that the uterus is irregularly enlarged. But patients having submucous myoma where you cannot palpate the myoma because it's inside the cavity, some patients presents with a smaller uterus. Okay, next.
So for allo 4, what are the diagnostic workup that this patient will need? So for the laboratory test, blood typing, pregnancy test, CBC and serum ferritin would be used to document the blood loss and to measure the hemoglobin and hematocrit to rule out anemia. And the serum ferritin is used to determine the levels of the iron in the body. The APTT or PT to rule out bleeding disorders. Then PSH and TRL is used to rule out hyperthyroidism or hypothyroidism and hyperprolactinemia. For the imaging studies, transvaginal ultrasonography is used to assess the shape, size, and contour, endometrial thickness, and adnexal mass. Flexible hysteroscopy is used to access the uterine cavity and to rule out any intracavitary lesions if presence, and MRI is used to detect presence and assessment of fibroid position, size, and number, and is also used to differentiate adenomyosis from uterine leiomyoma. Next.
Can you move back one slide? Okay, next.
Um, so for LO number 5, make an algorithm from vaginal bleeding, diagnostics, and management. So for the diagnostic approach, as what mentioned before, common causes is you have your palm cohen, your polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia, your coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not otherwise classified. So first is you have to take the history and physical examination. So this includes signs and symptoms of bleeding disorders, menstrual history, family history of cancer, medication, pelvic and bimanual examination. Then after that, we have to take HCG. So if negative HCG, first if positive HCG, so the bleeding is probably pregnancy related in etiology. For HCG negative, it can be divided into age, so less than 35 years old and greater than 35 years old. So for less than 35 years old, we can have anovulatory and ovulatory. So for anovulatory, we can have CBC, TSH, and prolactin. So we take TSH because based on the gynae books, it should be part of the normal workup because hypothyroidism denoted by increased TSH as well as hypoprolactinemia can also lead to anovulatory bleeding. Then, if it is abnormal, elevated TSH, um, then if normal TSH and prolactin, um, we can have some, we can ask if it is about for hyperandrogenism, signs and symptoms, obesity, or consider PCOS or uncontrolled BM. Or it can be if pelvic ultrasound, consider for, we have to take pelvic ultrasound and also we have to consider endometrial biopsy if greater than 35 years old or has additional endometrial cancer risk factors. So for ovulatory, we can order for CBC, TSH, coagulation profile. Then if the result is normal, then you can order for pelvic ultrasound and also consider endometrial biopsy if our patient is more than 35 years old. If the result is abnormal, then coagulation, abdominal abnormal coagulation, then we have to refer the patient to hematology. If it is elevated, then we have to take TSH for hypothyroidism. So if the patient is more than 35 years old, we have to check also the TSH, prolactin, ultrasound, and endometrial biopsy. So abnormal evaluation, we have to treat it accordingly.
So, when agreeing treatment options for heavy menstrual bleeding with women, we should take into account the woman's preferences or the desire to retain fertility and or the uterus, and then the benefits and harms of treatment, the clinical considerations like comorbidities, multiple pathologies, and the size of uterus, and other symptoms such as pressure and pain. So, for treatments for women with no identified pathology or fibroids less than 3 centimeters in diameter or suspected or diagnosed adenomyosis, uh, we can consider an levonorgestrel an intrauterine system as the first treatment for heavy menstrual bleeding in women with no identified pathology or fibroids less than 3 centimeters in diameter which are not causing distortion of the uterine cavity and or suspected or diagnosed adenomyosis. So if a woman with heavy menstrual bleeding declines LNGIUS or it is not suitable, consider the following pharmacological treatments. So we have non-hormonal, your tranexamic acid, and then non-steroidal anti-inflammatory drugs. And for hormonal, we have combined hormonal contraceptives and cyclic oral progestogens. So be aware that progestogen-only contraception may suppress menstruation, which could be beneficial to women with heavy menstrual bleeding. So if the treatment is unsuccessful, the woman declines pharmacological treatment or symptoms are severe, consider referral to specialist care for investigations to diagnose the cause of heavy menstrual bleeding if needed, and taking into account any investigations the woman has already had. And we have alternative pharmacological treatment um, options, including pharmacological and surgical options, which are second generation endometrial ablation and hysterectomy. So for women with submucosal fibroids, consider hysteroscopic removal. So treatments for women with fibroids of 3 centimeters or more in diameter, consider referring women to specialist care to undertake additional investigations and discuss treatment options for fibroids of 3 centimeters or more in diameter. So if pharmacological treatment is needed while investigations and definitive treatment are being organized, offer tranexamic acid and or NSAIDs. And then advise women to continue using NSAIDs and or tranexamic acid for as long as they are found to be beneficial. So and then for women with fibroids of 3 centimeters or more in diameter or the suspected adenomyosis, take into account the size, location, and number of fibroids and the severity of the symptoms, and consider the okay. Consider the following treatments, the one that I've said already, but for the hormonal, we have the additional ulipristal acetate. This is only indicated for some premenopausal women. And uterine artery embolization for fibroids, and then surgical, we have myomectomy and hysterectomy. So discuss with the woman the risk and possible benefits of intermittent treatment with ulipristal acetate. So advise that ulipristal acetate can be associated with serious liver injury leading to liver failure and the signs and symptoms to look out for. And then measure liver function before starting ulipristal acetate monthly for the first 2 courses and once before each new treatment course when clinically indicated. So if there is no underlying liver injury and surgery and uterine artery embolization for fibroids or adenomyosis are unsuitable or have failed, consider ulipristal acetate 5 milligrams up to 4 courses. For premenopausal women with heavy menstrual bleeding and fibroids of 3 centimeters or more in diameter, particularly if the hemoglobin level is 102 grams per liter or below. So be aware that the effectiveness of pharmacological treatments for heavy menstrual bleeding may be limited in women with fibroids or adenomyosis that are substantially greater than 3 centimeters in diameter.
So for LO number 6, how will you manage this specific case if you saw this in the emergency room? So next slide, please. So for the initial resuscitation or the initial management, so we must attend to the emergent clinical manifestations. So since the patient is already tachycardic and tachypneic, so and also pale, so we must administer intravenous isotonic fluids. Then if the laboratory results will be back and the hemoglobin is less than 8, then we can also do blood transfusion. So we should also administer oxygen and um, vital signs monitoring. Next slide, please. For the acute bleeding, um, we should give NSAIDs. Since the patient is also since the patient has a pain score of 8/10, we should also give NSAIDs. So examples are your mefenamic acid, 500 milligrams TID, and your ibuprofen, 400 milligrams TID. So we can also give antifibrinolytic agents for the bleeding. So your AMCA or your aminocaproic acid is also known as your tranexamic acid, and it should be given 6 grams per day for 3 days. And your epsilon aminocaproic acid should be given 18 grams per day for 3 days. So next slide, please. For the hormonal management to stop bleeding, we should give our IV CEE or your conjugated equine estrogen, 25 milligrams 3 hours apart, in 2 doses. Then after bleeding has ceased, um, we can now transition the medicine into the medroxyprogesterone acetate, 10 milligrams once a day for 7 to 10 days. Or if not available, since the most common is the oral contraceptives, um, we should give oral contraceptives containing 30 to 35 micrograms of estrogen every 24 hours. We can also give synthetic androgens such as your danazole, 200 milligrams daily. So if the um, patient does not respond to the medical treatment, we can now proceed with the surgical management. So the most um, easiest and the fastest way to treat severe bleeding would be your DNC. However, the definitive management is still the hysterectomy. So that would be all for the management.
Can you go back one slide? For this patient, what do you advise the patient as a management for her? Can you go
For
back
the
to the case?
surgical aspect, doc, or
Can
the
you go back to the case?
since the patient is already 40 years old, doc, we should appraise the patient that it is already advisable to have hysterectomy unless the patient wishes to have another pregnancy, doc.
Before hysterectomy, what will you advise her first? Not
Um,
40 years old with vaginal bleeding will undergo hysterectomy. You have to weigh the benefit versus the risk of doing a hysterectomy. First and foremost, you have to as much as possible, you advise patient medical management first. If medical management is not feasible, then that's the time you will do surgical, but not outright hysterectomy. For example, the myoma is only 8 cm and then intramural. You can do abdominal myomectomy, not outright hysterectomy. If the patient has a mucous myoma, prolapse of mucous myoma, then you can do vaginal myomectomy, not outright hysterectomy. You have to Consider the case of the patient. Your patient is only 40 years old, gravida 1, para 1. Maybe your patient is still desirous of pregnancy. And then the patient comes in with heavy menstrual bleeding. You have to investigate first. You do curettage, endometrial curettage, or endometrial biopsy. And then it depends on the result of the biopsy whether you can advise the patient for medical management or outright hysterectomy. For example, the patient has endometrial hyperplasia. There are medical management options for patients with endometrial hyperplasia before you proceed with outright hysterectomy. Did you get my point?
Yes, Doc.
Any more questions or clarifications regarding the management of the patient? So, di ba, you have different causes of abnormal uterine bleeding. You have the structural and non-structural. You have the ovulatory causes. The ovulatory causes can be corrected by hormones. So you cannot do outright hysterectomy. You do medical management first if it's feasible. If the patient has a very big myoma, that if you will do abdominal myomectomy, wala na mabilin sa young uterus, that's the time you can do outright hysterectomy. But do not advise patient outright hysterectomy. You have to consider medical options first before you consider surgical options. Any questions?
Doc, na ako'y question pero kato ni sa Gyne Module 1, Doc, na ang ang impression, Doc, di ba kay bacterial vaginosis? Unya, since
Yes.
yellow man to, Doc, ang ano, unya, ang sa bacterial vaginosis is white, and then sa trichomoniasis is yellow. So, dili i-disregard na lang ang color, Doc, ang character.
Some patients with bacterial vaginosis can also present with yellowish discharge.
Okay, Doc, thank you.
Any more questions?
Doc, can we ask for a photo op, Doc?
Okay.
Thank
You study well for your Kwanha, your OSCE, because I think there will be four stations, and then one station is